in the nation. And I'm thrilled to be here because just listening to the conversation around social structures, we are constantly trying to stress this idea of stop the blame game. Focus on the structures. Look around you at the privileges, at the access, etc. It's not an easy game to win because the narrative always out there is the blame game. So, happy to be here and an avid Spartan fan. So. I'm pleased to introduce Brenda Jagede. Did I get it close to your name? She is currently the project manager for PRIME, which is Practices to Reduce Infant Mortality Through Equity, which is housed at the Michigan Department of Community Health. Mrs. Jagede received her Bachelor of Arts and her Master's of Public Health Administration and her social work degree Master's of Social Work at the University of Michigan. Now, as project director, Brenda oversees the development of curricula, and she also implements a practice model, or the practice model, to improve the capacity for maternal and child health staff to reduce infant mortality. And Brenda is no stranger to the Michigan Department of Community Health. She has worked for them as a public health consultant in the areas of injury prevention, for example, HIV and AIDS, and reproductive health. Please join me in welcoming Brenda.
Good afternoon, everyone. Good afternoon, everyone. Thank you. Is that because I'm a go blue person? I want to say I definitely go blue. But I will say that my sister, who's 11 years younger than me, she was my baby, that she grew up only knowing about Michigan and then University of Michigan, and then she happened to go to Michigan State University. And her first semester, she said she felt really awkward and strange because, I mean, we would go blue, so that's all she knew, but she got over it very quickly. At the time she started Michigan State, I started having my children, so they had all this Michigan State clothing I was supposed to put on them, and I did. She's a good auntie, and I did. So my stepfather, he always says he has the best of both worlds because he can root for whoever he wants to. It's a good day when he's in Michigan. So I just wanted to talk with you a little bit about the PRIME project. I will, quickly go over just some of the data that we looked at the State Health Department that pretty much, helped us to know we needed to focus on infant mortality and focus on reducing disparities in infant mortality. And then want to tell you a little bit about our journey in terms of learning and understanding why we have these inequities that Dr. Kennedy has talked about in some of our birth outcomes and our other health outcomes. And then talk to you about PRIME, what we're learning, some of the changes that we started to make at the State Health Department. So if you, this first graph, just have a few graphs here. You can see that from 2000, our infant mortality rates have continued to go down in Michigan. We've had a couple of spikes along the way, but we've gone down, and even in 2011, our provisional data that we have, we went down even further to 6.5 in terms of the Michigan overall infant mortality rate. However, you can see that we've been consistently higher in Michigan than we are with the national rate. And we were not too happy that we were 37th among the states. So that was one thing that was continuing to be brought to our attention. This is another graph that's really important for us. That first red line shows the infant mortality rate for African Americans, which is about 16, the average rate over a 3-year period. If you look at 2008, 2010, the blue lines for our Native Americans at around 12, and then you have the state average there, and you have the Hispanic rate just a little bit above, and the Asian rate below our white rate. So we focused on the disparities with Native Americans and African Americans because they have the 2 to 2.5 times higher the rate of infant mortality in Michigan. Alethea has already reviewed this slide to show that even our 2011 provisional rates, we saw that the rates decreased for both whites in 2011 from 6, I think it's about 6.5 to 5.5, 6.7 to 5.5, and our African American rate reduced. But when we look closely at the data, which is something we've been learning to do over the years, we see that that disparity ratio went up from 2010 to 2011. It went from 2.6 to 2.8. So that's what we're focusing on. That's what's causing us, uneasiness. We're not comfortable with what's happening there. That gap is continuing to widen. And then just some data so you can see how different counties within Michigan are doing. You can see that the African American rate is 2, sometimes 3 times higher. And in Wayne County, you actually have double-digit rates for both black and white infant mortality. So we went about the process of saying, well, okay, we have these disparities. How can we better understand what's happening? What do we mean when we talk about equity and these inequities? And there's a process that we went through at the State Health Department. So one of the things that we looked at is a film. It's called Unnatural Causes. Can you raise your hands, anyone in here seen Unnatural Causes? Okay. Very good documentary that talks about all these social determinants of health and how they impact our health. But in one of the films called When the Bow Breaks, this was one of the questions that these 2 physicians had. They were looking at the cases that they had, and they said, why do African American women have babies that are born too small at twice the rate of white women? And so they had 2 things they wanted to look at and what they actually thought were the causes. One was socioeconomic differences, and the other one is maybe there's something genetically that's predisposed for African American women. So they found, in their research in looking at socioeconomic differences, they know that for every racial group, those who are more at risk are those who are not educated and who have lower socioeconomic status. So in every racial group, the better educated you are, the better birth outcomes women have. But they found that African American women who had college degrees were having poorer birth outcomes than white women who did not have a high school education. So that was puzzling. Well, what's happening? They have the socioeconomic status, they have the education. Why are their birth outcomes poor? And then they also looked at the genetics. So they said if it's some genetic thing that's happening, then African women who come to this country should have poor birth outcomes. They actually found that African women who come to this country, their birth outcomes are the same as white women in this country when they get here. But after a generation, their birth outcomes are the same as the African American women who were here. And they also found in looking at some of the other populations and some of the other films that when you look at, for instance, Mexican Americans, when they first immigrate here, they're looked at having better health status than Americans in general in terms of premature deaths, in terms of all the chronic diseases. But again, after a generation, they have poor health outcomes than others in the country. So the question is, what's happening in these contexts of the United States, that's causing, or it seems to be having a role in these poor health outcomes. So Dr. Candy already did a great job about talking about the social determinants of health and the root causes, looking at the root causes, things like institutional racism, classism, sexism, and those are terms that we were becoming familiar with at the State Health Department and exposing our staff to. Alethea, I think, and Dr. Kennedy talked about life course theory, but I wanted to mention that not only does it talk about our whole life course and what it means, but it's a theory that points to broad social, economic, and environmental factors as the underlying causes of the persistent inequalities that we see in health. So when we see it over generation and generation, and we see it in populations persistent, that there's something else happening. We always look at one of the things, definition of health equity. I just, came across this information from another, it was in Michigan, some data that we looked at, where we were able to achieve health equity in Michigan. And all babies had the same chance of surviving. In 2009, there would be 235 babies who would have lived past their first birthday. So in some of the trainings that we've done, I'll talk with some of the trainings we've done with some of our Native American colleagues. They try to make it really clear that it's more than just statistics. These are our babies. They belong to someone, some of our families, our friends, and our loved ones. We also looked at some reports to help us understand what's been happening. Anyone read the report, Unequal Treatment? No? This was a very eye-opening report, and I would say, I think, very much so for the healthcare arena, because it showed that across virtually every type of intervention, from technology to interventions and treatment, that people of color receive poor quality of care. Even when they control for things like, well, they have poor socioeconomic status. Oh, they have lack of insurance. When they control for all those things, they still have poor quality of care. And I think it really opened our eyes to our own biases. We all have biases. We all have grown up in this country. We've all been exposed to the stereotypes, whatever it may be. And good intentioned public health folks and doctors, and the like, their patients were receiving poor quality care. So it was an eye-opening and a way to just be aware of what was happening, and that's what we were doing at the State Health Department. Some other reports that we took a look at, Robert Wood Johnson, again, as Dr. Kennedy said, look at your zip code. I can tell you pretty much how long you're going to live, versus whatever you're doing individually. So we really were trying to look at more of population-based factors, all those social determinants. Another report from the Joint Center of Political and Economic Studies, where it's wanting to bring attention to, this is what it's costing us in the United States to have these health inequities. So it looked at between 2003 and 2006, if you look at the combined rates of these disparities and premature deaths, we could have saved $1.24 trillion. I didn't go far, but I tried to figure out what could we have done with that money, in the United States. What kind of progress can we make? And then even in Michigan, our own behavioral risk factor survey, we looked at the adult productivity days that are lost due to disparities in physical and mental health, and over 54,000 days. So just looking at how we could be making improvements. So in Prime, these are our objectives, and our main task was to develop some type of practice model so that our staff would be able to address the racial disparities that we see in our race between African Americans and white and Native Americans and white. So we wanted to build this comprehensive strategy. The second was to develop partnerships or continue to have our partnerships with the local communities, because it's imperative in what we do as a state health department, but to really understand the work that they had been doing in their communities for some years before we as a state health department decided to look at this approach and look at the social determinants of health. They had been talking about things like racism. They had been connecting all of those services around those social determinants of health. So we wanted to learn what their best practices were. And then whatever it is that we are establishing in terms of changes in our policies and our practices, we want to make sure that we have some quality improvement processes in place. So I think Alethea mentioned, thank you, we have our project is Kellogg funded. We've had funding for 3 years. We're actually in the process of applying for some additional funding. We have a steering team that I'll show you really quickly that oversees the initiative, and we had some various work groups. And I just want to mention that our Native American ad hoc work group, I think that was a surprise to us in the project. I don't think we really knew that we would be focusing on the lack of data that's in the Native American community, that would rise to one of our top things that we needed to address. This is our steering team, various areas within the public health department, including our health disparities minority health section. Epidemiology was very imperative for us to partner with our epidemiologists. University of Michigan helps us with our evaluation. Vanderbilt University has a professor that really helps us build our model. local public health. Wayne and Ingham County has been imperative in terms of doing health equity social justice trainings for us. And our community-based organizations, the Corner Health Center and the Intertribal Council of Michigan has been really helpful in us trying to understand what's happening in our Native American communities. Our local learning collaborative, all of these Healthy Start, Healthy Start projects that really look at improving growth outcomes. So community-based organizations in many of our health departments. And most of them, again, have been doing work in this area. So this is what we've been doing in Prime. The first thing was to provide our staff with some overall training around this. One of the first trainings they went to was Undoing Racism. I joke and say that when they saw Undoing Racism, they were lining up and couldn't wait to go to that training. Everybody here would line up and couldn't wait to go to Undoing Racism training. So it was really, this training was facilitated by People's Institute for Survival and Beyond. And they've been doing this training for a couple of decades, nationally, you know, they've been doing training internationally. And it really was looking at understanding what do we mean when we say racism, when we say institutional racism. You know, looking at a historical perspective in terms of what happened and policies and why we're where we're at now. Kind of like the discussion I hear about Detroit and the bankruptcy. It didn't just happen today. So what happened back here to get us to where we are today? You know, so that's the kind of those are the kind of conversations we're having. But when I joke about the Undoing Racism training, we had our white staff who did not want to go to that training. They did not want to sit through the training and feel like they were being blamed for past historical things that had happened. We had our African American staff who did not want to go to that training. They did not want to go there and talk about their experiences of racism and feel like they were being not believed, believed. So that was a process for us. But at the end, we did see statistically significant improvements in the content knowledge of our staff. We found that even though our white staff came in and their scores on their for their competencies were lower than our African Americans, by the time they ended the training, they were actually at the same level. So we learned that there was some knowledge gained in those trainings. And the majority of our staff did state that they will recommend the trainings to their colleagues with no reservations, without any reservations. So going in, they didn't want to do it, but coming out, they saw some benefits of it. And then our health equity social justice workshops were facilitated by Ingham County Health Department by our own Dr. Kennedy and Doe Bloss. And it was, again, showing the importance of us to look at the importance of a health equity social justice framework in our work, how to have dialogue, and as Dr. Kennedy would say, not debate, you know, not those kind of discussions around this, and how to really look at the root causes. And then the Health Equity Learning Labs was really the one area within Prime where we developed these Health Equity Learning Labs, because after the staff went through those trainings, they still stated, well, what do you want me to do differently? What exactly am I supposed to do in my work? So that is what we were trying to do in our Health Equity Learning Labs. We developed the labs. The first labs were piloted by our WIC staff, and they actually came out with 4 different equity plans, and I'll mention those in a minute. Our Native American Pregnancy Risk Assessment Monitoring Survey, I always have to think that through. We had a standalone specific survey, because, and this is a survey that is given to all women who have just had a birth. It tells us a lot about their socioeconomic status, what was happening with them, etc. But it did not give us any data or enough data on the Native American population, the survey that we do every year in Michigan. It didn't tell us what we could do for the one population that had the highest disparity. So in partnering with our Intertribal Council, they taught us and gave us a way to have a different approach in terms of how we even distribute the survey. So traditionally, when we do the survey, we identify an infant's race based on the mother's race. the Intertribal Council of Michigan showed us how we would look at both the race of the mother and the father to identify people to send a survey to. And by using this new approach, we were able to get 108% increase in our response. I mean, in those that we could survey. So that helped a lot. And then also the approach that we use where we partnered with the Intertribal Council, we informed and worked with the tribal communities to let them know how important the survey was. The survey was coming while we were doing the survey. We included a couple questions they wanted on the survey. And so we're really happy that soon we'll get to see and analyze all the data that we collected for all births in 2012. So that's, sometimes to me when I say this, it sounds simple, but this is something we were not doing. This was not a practice that we were used to practicing in Michigan. And we actually still have a little pushback, but CDC and some others are now looking at our approach. They want to see, well, what do we do in Michigan? Alethea already talked about the health status report. We have looked at some of our policies in Michigan, all of those policies around the social determinant, to try and make a clear connection to how those policies have impacted birth outcomes. We're still in the process of doing that. And we developed a website that has a variety of videos describing health equity, a lot of resources, talking about what the local communities have been doing, what the state health department is doing. And some of these I've already talked about in terms of some of our policy changes and our successes. But I will say that first bullet, many of our staff, once they went through the trainings, they found it was very important to give that same training to all the local providers. So to some extent, our family planning, our adolescent health, our fetal infant mortality review teams, they provided some training to the local providers. Our contracts to local health departments for maternal child health now is asking, well, tell us about your health disparities and tell us what have you seen in your health disparities. It's something that we hadn't asked them before. The Nurse Family Partnership Outreach Project, I'll mention this and then close. This project is a home visiting program for first-time moms. And what we did, we had our epidemiologists look at all the specific communities, look at the data, and tell them these are the populations where you're having excess deaths. These populations are experiencing more deaths. So I want you to change how you've been recruiting, and I want you to go to these populations and recruit for this project. And again, sometimes I say this and it sounds so simple, but this is not what we were doing. This is not what we were doing, and we got some pushback from the communities. We got it. Alethea said a lot of pushback, and she would know when she was our director. Got a lot of pushback on just something like this, but the staff said that one of the reasons why they stood firm on this requirement is because of the training that they had gone through, because we were trying to make that cultural change within our department. And the same thing happened with the WIC health equity plans in terms of one of the efforts were to, that they identified was to outreach to the Native American community. And they say, actually the director told me a couple weeks ago that they would not have done that had they not gone through the health equity learning labs, where they were open to one of the community services organizations here in Detroit that provide services to the Native American community saying, bring the WIC services to us. We already have our population here. Let us have the services at this facility. And that's something that they hadn't done before, but they said they were open to that. Not that it's easy and they're not learning a lot, but they would not have done that without having gone through this training. And then I've talked about some of the things that we're learning. And again, prevention is just key. You know, the whole life course theory, everything is about making people as healthy as they can be. Well, we already talked about population health factors. I mentioned some of the home visiting programs because they do, they may not address all of the social determinants, but they are collecting data and information and providing resources around those. Partnerships is just key. We can't, at the State Department, just decide what needs to be done. We have to partner with the local communities to know what needs to happen and doing something just a little different sometimes. And there's some resources for some of our websites. Thank you.
part of the program where we ask questions to the speakers. And as a facilitator, we have Dr. Michelle Reed here. Thank you to my friend Sandy Weir, who's a good friend, talked her into doing this for us. And she is a medical director of Community Network Services. I hope I'm saying that correctly. And her boss is back there. So thank you, Dr. Reed.
Thank you so much for inviting me, and I'm glad that Mr. Michael Garrett, our CEO, was able to attend. And you might ask, why is a psychiatrist interested in infant mortality? I think one of the biggest concerns that I had being able to read the reports and looking at it had to do with that smoking and untreated depression and substance abuse are major risk factors for poor outcomes. And I just encouraged, I'm excited tomorrow that you'll be in Lansing, repeating this again, that Representative Tlaib and Stallworth joined us, even more legislators tomorrow, but continue to engage the mental health and substance abuse community and primary care to really address, at CNS we treat about 5,000 adults with mental illness, and smoking, almost 45% of the individuals smoke. Obviously, depression and substance abuse are big risk factors that really we're tackling in Oakland County, and we're excited to be able to have this conversation, and we'd like even more so to see mental health and substance abuse and physical health at the table for this conversation.
And I would add that we also found experiences of discrimination and racism were closely correlated to depressive symptoms, which then affects pregnancy experience and outcome.
Absolutely. I think we've also been involved greatly with the infant mental health program in Wayne County, and that was one thing that we actually found in terms of the outcomes for the infants. We started working with the children from ages 0 to 6 months, and that when the infants who did best were those whose mothers had untreated or undiagnosed depression, and with the infant mental health services provided, that there was an increase in compliance, increase in the diagnosis, and marked improvement in the overall mental health of the women when they participated in infant mental health. So we're seeing that maternal depression has an obvious impact on the child's development even after birth. So that's also a big issue that we think bringing these groups together is really important.
A question, it's a little bit probably too specific, so I don't necessarily expect an answer, but do you know if there's been any international research in the last 10 years or so, somewhat recent, being able to show comparative analysis of, social determinants of health from, let's say, in different parts of the country where there is institutional racism and similar problems that we have here, but then comparing healthcare systems. So while there may be institutional racism, showing any kind of impact of more equitable healthcare services and how that impacts those populations in other countries that may have more equitable health access but may have similar institutional racism and other socioeconomic similarities to ours.
There absolutely is. Michael Marmot is somewhat dips in that with the UK research, and other names escape me, but there's absolutely a growing body of literature that has an international comparison to try to help us learn some lessons. Yeah.
And do you remember from the work, does it show a fairly sizable impact from having more equitable healthcare access, or does that not have as big of an impact as?
I think the biggest variable that they're looking at is economic disparity, or countries that have greater economic equality tend to have less of the negative outcomes that we're seeing. Marmot's work is showing that we're really seeing a trajectory, a very linear relationship, so that middle class folk have better health than lower class, for lack of a better word, lower SES, and middle class have worse health than upper middle class. Wealthy have better health than upper middle class. And it really is a linear relationship, and economic inequality, when you have more differences between the haves and the have-nots, then you see these huge outcomes, differences in health outcomes.
One question I had, looking looking at the report from Louisiana and the impact study, they were talking about a policy of, for instance, certain low-income women would be covered only during their pregnancy and then for 6 days after. And the report seemed to be saying that you really need to pay attention to women's health throughout the whole life cycle, the preconception, interconception. And I was wondering if you all had any thoughts about the implementation of the Medicaid expansion and the health exchanges. Would that potentially have the impact in Michigan on the birth weights or also infant mortality, and how would we begin to look at that to see the impact?
Well, I'll start and you can add. We were really excited about that piece of the Affordable Care Act because it would allow women to have access to health care before pregnancy to help address some of those chronic conditions that need medical care and attention that women weren't addressing because they didn't have insurance, like diabetes or high blood pressure, that only got addressed during pregnancy and then, as you say, got cut off after 2 months postpartum. So we're hoping to see, yes, some improvements, but time will tell. I don't know if you want to add anything.
I was just going to mention that in terms of the preconception and interconception health, I know that I think there's a few communities, but I know the Kent County Health Department actually talked about their project and how when they were very sad when the state cut their funds because of lack of resources in their preconception, interconception health work. But when they had those fundings, I don't know if they had it restored, they were able to find other funds for that, how they showed specific increases in birth outcomes when they had that service for the women. So I just say that to say that, our decisions to make funding, cuts, it affects the, lives of those women, and they show very much so that it's not about just that 9 months. 9 months is important, but you gotta get them healthy beforehand, and you gotta get them healthy in between the births. So that was a really important.
And I did notice in the report that one of the states actually decided that they would pick certain high-risk women who, for instance, had a low-risk baby and then decided to continue their coverage in between anticipating. Well, one thing you do talk about budget cuts, and I'm working with the state, I wonder, again, we're in a situation in community mental health where there was a substantial portion of general fund dollars spent on mental health and substance abuse services here, maybe $30, $40 million a year. And everybody in Lansing was anticipating that the Medicaid expansion would start January 1st, so they eliminated all the general fund out of the budget. Here you go, the Medicaid expansion is not going to start till April, so we have this gap of time where we have these individuals with no insurance whatsoever, no Medicaid, some of them in some relatively intensive services for whom there's absolutely no coverage for this 3-month, 6-month period. And I'm wondering, how do you see the upcoming budget cuts that are affecting, I think they affect public health, substance abuse, and mental health as far as our planning or what the policy issues are behind that? Any thoughts?
I know they're trying to.
Dr. Reed wants to get us in trouble. The challenge is policy development is a negotiation. And I always argue that there's nothing worse in my mind than compromise. Because compromise means you don't get what you want, really. I don't get what I want, really. We settle on this and then we pretend like we're happy about it. And so certainly the Healthy Michigan Fund is progress. My home state, which is North Carolina, turned down the federal dollars. So I'm happy with what we've done in Michigan. And we'll have to, I think, begin to think about what were the unanticipated negative consequences of some of our policy making and how fluid is the policy decision-making process so that we can easily revise and tweak. And I was going to just comment, my colleagues, I travel a lot nationally speaking, and I always commend the courage of the two women sitting before you, because to do something as simple as saying, we're going to provide this service to African American babies because African American babies are dying the most, and Native American babies seems, just so simple, but the American narrative is that fairness equates to sameness. So anytime we try to do something different for a different group, even though the need and the evidence and the documentation is clear, you get lots and lots of negative pushback. And certainly Alethea Carr has just bore up under tons of criticism coming up from the ground and from her bosses who are greatly influenced, or her big bosses, a political appointee. So he's got to be cautious, others have to be cautious, and she's sort of getting smashed in the middle, standing the ground so that we could see babies living longer in Michigan.
Hi, I'm Kadada Green from Black Mothers Breastfeeding Association, and I feel as if it's my duty to always put breastfeeding on the table. And I was looking through this plan, and I just glanced through it, so I could have missed it, but I was looking for something specifically related to breastfeeding. Because according to the Center for Disease Control, if Black babies were breastfed, then our infant mortality rate would drop in half. So I'm wondering, outside of the CDC supplemental grant for physical activity, nutrition, and obesity, which just ended September 30th, of which we were a part, and WIC, what other state initiatives are directly addressing breastfeeding, and particularly the disparity rate that exists with Black babies?
One of the strategies that's part of that infant mortality reduction plan is to have a breastfeeding consultant that works across the Bureau of Maternal Child Health, that will allow the work to not rely just on the WIC division, because as you said, WIC has been funded to do that over time, but we recognize they can't do it all. And I'm not sure about the current status, but I understand that the position was to be filled this year. So it is a major component of it. We've also included training for those involved in home visiting on breastfeeding, and to not only help them understand the things that can be done by those home visiting programs, but also the breastfeeding resources that exist in their community, so that they can help connect families or women with breastfeeding resources that they may need. And we're also in the midst of working with WIC, and we have a special project with our high-risk, the NICUs, our high-risk intensive care units in birthing hospitals, to make sure that breastfeeding consultants are available to those women as well. So, and we have another project that's helping to make breast milk available to low birth weight infants. So it's on the table. It's a key component. I'm a dietitian, so it had to be there.
Let me just caution us, though, that there's no, everybody has their agenda.
Yeah.
So Safe Sleep folk are going to say, remember that none of the interventions in and of themselves are going to explain all the variants. So we're talking about really a collective impact model, with, for us in this state, being MDCH being sort of the backbone organization, but it's every part of this interacting together.
Yeah, I was reflecting on your conversation about racism and how it affects and puts stress on the family. And on the undoing racism, I've been to that seminar. It's amazing stuff, so I commend you again. Do you do work, or perhaps that's exactly what you do, I don't know, but I had a student who's a social worker, and she deals with children and will take them out of the home if they're being abused. And she felt very strong, she's African American, that she had to educate her colleague, who was a white social worker. They were in a home, I believe. White social worker went into the home, and said they wanted to pull the child because the mother was not providing, the kids were hungry, she said, or weren't giving them good nutrition. The African American social worker went in, and she said, that ain't the issue, because there's cereal there, it's sugary cereal, but there's food in the house. It ain't the best food at all. It's the cheap processed stuff, which we all know subsidies are going towards in this country. So it is what is the cheapest food available. However, the white social worker was telling the mother off and wanting to pull the kids. Now, if that isn't stress, I don't know what is. Clearly, she just needed some intervention around maybe better food, more food stamps, where to get better food, etc. It had nothing really to do, but again, it's that cultural thinking. If you haven't been in poverty, you won't understand it. Is that kind of some of the pieces you're getting at as well?
Well, that's definitely something that we're, looking at the health department. And so even if what we're doing in crime, we think that this model is something that could be shared throughout the department. So in our Department of Health and Human Services. And we had another project, we had a collaborative, it was partnerships to eliminate disparities in infant mortality. And we specifically sought to have our colleagues from Medicaid and Human Services as a part of that, because we knew that the statistics showed that African American children were being pulled out of the homes more so than our white children, where they would have some of the same scenarios, but they would be getting pulled out. So we were hoping that this training, this model can, go to those other areas of the health department, but it is a focus of ours, and we hope we can spread that.
One last question. Or two.
Hi, I'm Sue Franklin. I'm with Southeastern Michigan Index, and I'm the assistant in charge of Indians. And mine is about tobacco. It's no coincidence that the highest rates of smoking are African American and Native American, and that's what mortality rates are too. Is a contributing factor. But part of it is the target of SES and minorities like tobacco companies. And that's deliberate. There's many people who Indians who abide in American spirit because they believe the program that it's a pure form of tobacco and it's not going to hurt them as much. It is safe to use that for pregnancy around their children. And that company's owned by R.J. Reynolds. It's the same tobacco as everybody else. So that's the area that we're working in. We had a situation last year where kind of the child of Mopar here in the past couple of years, we've done some fundraising activities for us. One of the things they did was like a baby shower type of thing where company-wide they collected all these furniture and clothing and diapers and things like that. So we put that out to Macomb County Head Start as well as DHS up Macomb County. And we had people coming from the Starways, Genesee County, Wayne County, coming in to get diapers. And we had half the audience was behind there because we had to fill out a little survey, collected some data. We had peer-to-peer counseling there. Tobacco use was secondhand and third-hand smoke. What's happening, what we find is all of us who are experts in the field are not getting to the field. We're just not getting to them. We have to find a way to get to them because they're open to the information. A lot of them had not even heard of this until we had staff that was sitting down and talking about that. So I'm really happy to hear that you're working with the Native American population. We have representatives from one of our sister agencies, American Health and Family Services, does a Healthy Start program. And it's heartening to hear that you're working with the tribes. One of the reasons that data is not available is the tribes are in competition with all these other groups that are funding. So they have a tendency to hold that data close to them and not share it. And I just think education, persistent efforts, and collaboration is really going to kind of take care of that. But thank you so much for the work that you're doing and you're continuing to do.
Mike, you had a question?
Yeah. I think it was during the presentation that Brenda did about unequal treatment when people or African Americans go to see their physicians. I guess the question that I had is what kind of difference are we talking about with regard to the level and the number of procedures that are received from one ethnic group to the other? How big is that difference?
I don't know that I know the exacts of that, but in just some of the things that I was reading, for instance, for someone to get an amputation versus non-amputation, that more so African Americans or people of color would get amputation versus, other services. But I don't have the exact,
Well, I mean, that whole report really began to cause us to start thinking about not health inequities, but health care inequities. Looked at procedures that were ordered by clinicians, things like amputation of a limb, any type of cancer screening, basically any procedure, and found that blacks were less likely to be referred for any of those procedures, except for two of the most egregious ones, which was amputation of a limb and bilateral testicular removal. All of these probably secondary to some condition. Limb amputation, probably from diabetes. Testicular amputation, probably from prostate, some type of cancer. But that was the first study that began to show us there is something happening differently in the decision-making of clinicians across race that is causing procedural inequities to occur. And that's when we began sort of pushing more deeply into the why of this, what's going on. And we are all products of our environment. I mean, there are all types of clinical studies that look at cross-racial interactions in social work, in nursing, in physicians. One research that was actually a camera in the room that studied when you're cross-race that white providers had less social engagement, had less sort of setting the context and beginning the rapport kind of interaction with people that were of a different race than them. Now, are they intentionally being, alienating people? Absolutely not. But we also know that it's people of color that have more issues of trust with providers who are white, so you almost would want more social chit-chat beforehand. So as we begin to learn these things, we begin to train future generations of clinicians differently so that they're aware of these things, and it doesn't mean you're a bad person. It just means we have all been raised in an environment that's pushing us to these types of interactions.
So rather than look for root cause issues to someone's medical condition, I'll just cut your leg off and be done with it kind of stuff.
I mean, we tend to go with the easier, what's easier, and in that study,
or make assumptions about what you can do in terms of preventing this to happening,
Right, that you don't have the capacity to, to do X, Y, Z.
Okay.
I mean, it's amazing stuff when you finally look at yourselves in the mirror, and then when we look at ourselves in the mirror, instead of running, saying, I'm not racist, well, none of us are racist, so to speak. I mean, there are a few that probably could wear that label, but most of us are not. But we are not yet a post-racial society where race doesn't still, at times, negatively impact our good intentions.
You talked about a collective impact on web of prevention services. Is there a specific area that you feel that you're missing and that you guys are really pushing towards bringing into the prevention fold?
Well, I mean, we could answer that a lot of different ways. I think I would argue for employment. If I could get half of the folk that I serve at my local health department, if I could get them gainfully employed, it would solve a ton of problems. We talk about what is that catalytic decision that's going to precipitate lots of other things, but I don't get invited to a lot of employment planning meetings. I'm trying to, as a health officer, to say, you need me at your table. But that's a huge one right now.
Yeah. Go ahead. I think we both were thinking education might be the other. Although we work with education some, I think that's an area that we could do more collaboration on. And I just wanted to mention one of the things that has come up recently in this area is this whole discussion about eliminating that I-375. And we talked about access to healthy foods, more walking paths. That's another decision I think public health should be at the table with, because if we do eliminate that, it will give more walking paths. Perhaps people might have more employment opportunities because they will get into the neighborhood. So that's just another way to kind of put it into practice.
And there are some communities where there is you could probably throw the stone over to the healthy food resource, but there's no way you can walk over there. The only way you could get there is to drive down there and then drive over there and then drive back. It is about walkable communities.
Right.
Any other questions, comments?
I'm really troubled by the unequal treatment document because it talks about personal a bias which is driven by a lot of the models that we see in this society. People of color are rarely projected in the media as people who care about their bodies or their children, who are accused of randomly giving birth. When you say feed our children anything, it's almost as though that's an intrinsic value in our families. And I'm wondering if the public health division somewhere, we could get better messages about our families, because embedded within people's consciousness, an internal model of worth and how they see people. We're constantly projected as these willfully random, uncontrollable. When's the last time we've seen you on you incredible women? Who knows that you exist? But let Pookie rob somebody, he's all over it. And it's very profound. I mean, we talk about it all the time. But I think something we could do is we could just show an African-American family loving their baby, breastfeeding, a father taking it, and it's a part of our community. That is a reality. We know there are problems in our community, but there's never a provision to change those internal models of people who do then get control over our care, our psychological care, our physical care. And they can't be held responsible when the message is that we don't care, we're not able, we're pathological, we are the problem of the country. So I think some of the things we could do is make sure that when we have advertisements or projections that we are shown in a positive light. And we pay daunting price to raise our children every day. As a mother of black males, you can't even quantify the price we pay to keep them alive every day. i.e. college, whatever they have. They're still in the vanguard, being murdered, locked up, whatever. We pay an incredible price to be mothers.
You know, I want us to, they'll be very intentional and very mindful. And what I have begun to see is that we're slapping diverse pictures on the wall, but we're not changing the foundation of what is needed in the community. So it is both and. I mean, yeah, blood and gore sell in this society. Maybe we should work on changing that value. But the media is going to follow, you know, what's happening. The news is going to report what's happening. People are traumatized. So yes, communities of color are disproportionately engaged in law-breaking, violent types of events. That's what's on the news. That's what Hollywood does. So it's all this, it's this completely connected system that we need to do. So yes, while the media, while our advertising, we need to be mindful of the faces that we project, but someone also, it's my both and slide, don't just say, let's have better pictures of us looking good. Let's also say, while those of us that are good at media and marketing, also have our policymakers say, why is it that Native American families are more predisposed to smoking and this and that? You know, so it's both of us, all of us doing the work together.
Yeah, I'm going on with that, the policymakers, because I'm thinking about, has anybody heard of ROC, which is the Restaurant Opportunity Group? What they're trying to do is pass an ordinance in the city for a good wage and also not expired food. Because many of our seniors or women or whatever are going down to gas stations or wherever and getting bad milk, bad, you know, apples, whatever. But of course, the narrative on it is going to be bad for business.
Right.
Is there an arm? Where do we go if we want to lobby, or who would you suggest that we do that to? Or do you have a suggestion?
You know, public health is now just recently part of a project that Centers for Disease Control, probably we shouldn't say that loud, is allowing us, facilitating for us. And it is partnering public health with community organizers as a discipline. Not as community, I mean really the science of community organizing and how do you move in a strategic way. So we are pleased in Ingham County to be hosting a grant by Kellogg that has funded 5 areas in the state to try to look at bringing public health with community organizers to figure out what is the shared issue across the state and how do we let those constituents, those community organizers that work with all those constituents, really set the agenda and push our bosses, quite candidly. So Moses here in Detroit, under the leadership of Poncella Hardaway, is our partner. And so I think getting students thinking and at least understanding that strategy is a real ripe opportunity.
I was also going to mention, if the Food Policy Council isn't a part of that work, they probably should be. I know they're active here in the Detroit area.
Yeah, and they also said there weren't enough health inspectors too, which is really true.
Well,
Which
that's
is
because
really
the
interesting. Or
Detroit,
so they say,
well, the
but it's-
Detroit Health Department is, you know, in transition and doing some huge structural things right now, or in the midst of implementing those, so, but they've hired more, I don't know, the health officers, the health officers, Vern Davis Anthony, and the Institute for Population Health is the other nonprofit group that's doing a lot of population health in Detroit, and that's Loretta Davis, who's the CEO for that.
Any other questions, comments?
Well, you know, I was just thinking, when you said that you did a control for the disparities among blacks, and when you did that, there was still a variance, correct? And then I heard later that you were saying that clinicians, they themselves don't rather amputate as opposed to taking through a procedure or an introduced procedure that might be able to save an arm or limb or leg. Or they would rather not give you a prescription. Are you doing, is there anything being done as, I guess, as a, to educate the clinicians or to a task force or whatever to see what they're doing to stop it?
Well, let me clarify first that I don't want to ascribe preferential treatment. You know, clinicians made their clinical diagnoses, they did their differential diagnoses and did a plan of care. And then, you know, mean people like sociologists like me came in and just looked at the trend. So I don't want to ascribe you prefer to do that. You see what I'm saying? So we don't want to over-interpret our results. We want to just look at the results and say, so what does this tell us about our health system and what do we want to do differently? But there is a ton of work as a result of that same IOM report that's looking at cultural competence, cultural humility, all types of things like that around clinical providers.
So in other words, there's a lot of work in the Detroit area. Henry Ford's doing, it's called WIN now, I think. I forgot. Women, do you remember what it stands for?
Information network.
Women
Inspired
Information
Neighborhood Network. Women Inspired Neighborhood Network.
Inspired Neighborhood Network. But I know that they're doing some training with providers around these issues and cultural competency. There's a lot of different efforts within the Detroit area.
Hi, I'm Sonia. I'm actually a second-year medical student at Wayne, and I'm just doing pediatrics, so I can do this talk. But we actually watched the video, was it A Natural Cause? We watched that during our orientation meeting, and we actually have cultural competency lectures about our 2 years, and then I think our rotational years as well, addressing why this occurs and kind of keeping in mind that we're making these unconscious biases. So I think there's a lot of implementation taken for future positions and training.
Right. And you're going to the community model rather than the medical model.
Yeah, the community-centered medical health.
Are you with Wayne State or Michigan State?
Wayne State.
I do know that Michigan